Good morning everybody. Today we are doing a live demonstration of a young athlete. He is a 22-year-old male patient, injury to the knee while playing football, and we will be discussing the MRI images now, and then we will be shifting on to the live surgeries, and we will be doing the live surgeries utilizing the Advanced systems, which include eco button flex and the peak knotless buttons for the tibial fixation. So now let's focus on the MRI per se. So if you see the MRI here, you can see the sagittal images of the left knee, and we can see that when we go from medial to lateral, there is an undersurface tear of the medial meniscus, which is seen in the third image. This is very important because this is a very common injury which is associated with ACL tears. And when we go laterally, we will see that the ACL ligament is not well visualized. The ACL here is not well visualized, it is not seen, which we can follow up here. So there is a small, if you see this small lesion, so there is a small like a stump also which is there, which is flipped on itself, and on the lateral side also you can see a small hyperintensity on the lateral meniscus, but overall it is fine. Again on the GRE images we can still see that there is a undersurface tear of the lateral meniscus going laterally. Again there is an absent ACL, and the images which are seen in this way. When we see the coronal images, we can still realize that here you have a tear on the undersurface which was seen on the sagittal image as well, which is seen on these and these images. Two images you can see the undersurface tear, and we will be repairing it with the advanced technology of the meniscus repair. And then you can see that the notch is not very good, so that is also again a indirect sign of a tear of the ACL which is visualized here. The axials are pretty good, so probably the patient would not have major patellofemoral issues, so grossly normal axials. So let's start with the live surgery, and I'll be focusing on the technical pearls during the live surgery. Thank you. So good morning everybody. So we are starting the live surgery. Before starting the live surgery, I would be just demonstrating the position and the portals. So this is our routine setup that we do. We usually do it in a supine position, and we use this kind of a leg holder, and this is very advantageous because we can actually change the flexion as per our wish in any patient. And so whenever we want to drill the femur, we can increase the flexion. When we want to decrease the drill the tibia, we can decrease the flexion. We usually hold put a side support here to give thigh support, so the thigh does not fall back here. So this is by and large supine position with a stand with a variable flexion angle options. This is our best setup that is required for a ACL surgery. Now as far as the portal is concerned, we have marked the portals. So this is the patella, this is the patella tendon. We have to make a lateral portal which is little bit higher as compared to the standard lateral portal, and then you have an option of making two portals on the medial side. But what we have seen over time is the two portals are very close, and there is a problem of the wound necrosis in between the two portals. So we have started making a single portal which is little bigger in size. So we will make around 1.5 to 2 centimeter single portal on the middle side, which will be working as both the medial portal and the anteromedial portal. So we can actually use two instruments simultaneously through that portal. So that is another advantage that we have with this kind of a system. So now today we are using osteocare system, and the system will consist of an all inside equivalent sort of an ACL reconstruction with button fixation on both the sides. Whenever we are doing an all inside equivalent fixation, we always augment it with the use of a fiber tape. So again, this button, which is an eco button flex button, it comes with an integrated fiber tape. So the fiber tape is integrated into the button, and that can be tightened on a separate slot which is given in the peak button on the tibia. So on the femur, we will be using the eco button flex, which is a hybrid loop button. The button is an intermediate button between a fixed loop button and an adjustable loop button. And on the tibia, we will be using an adjustable button with a peak button. So that is the peak button is a 17 mm button. It fits nice, and it has got the slots for the internal bracing as well. So you not only do a ACL, but you can augment it or secure it with the use of an internal brace as well. So let's start the live surgery. So we'll be starting with the diagnostic arthroscopy, and as I told you, I usually press the inferior pole of the patella. By pressing the inferior pole of patella, you will have two prominence, which is on the medial and the lateral side, and usually of the surgery we have just performed here. With me are Dr. Shashank Chandra and Dr. Anil Choksi, and they will be asking various questions which is pertaining to the live surgery that we just performed. So you can ask your questions, whatever is in your mind you can ask, and we will be having a group discussion on to that.
Sir, my first question will be, is there any difference between the surgery we performed, we use a suspensory system as compared to the aperture system?
So both of them are very good techniques. The aperture fixation has its advantages and suspensory fixation has its advantages. But here, pertaining to the advantages of this system, this is a suspensory fixation on both the sides, and the advantages you get is you can tension the graft on both the sides. You can tension it on the femur and you can tension it on the tibia, and the tensioning you get with this system is little better than the tensioning you get with the aperture fixation. You do have a fixation which is apart, which is a little bit far from the healing point, but still the tensioning part is good in this particular system. The aperture fixation is not that, but that is compensated with a good tensioning and the good amount of circumferential healing that we get. Because if you put a aperture fixation supposedly, then the healing diameter of the tunnel decreases. So here we have a circumferential healing and the tensioning is good. So it's a little better technique as compared to a screw standalone fixation.
Okay. Sir, does it make any difference in a rehabilitation protocol?
Yes. So by and large the rehab protocol is same, but in this particular case we have incorporated internal brace, and it is postulated, although it is controversial, that with the use of internal brace you can mobilize the patient little faster, plus the chances of re-tear rates will go down because it will act as a seat belt and it will prevent the re-injuries to the ligament per se. So although it is little bit of controversial thing, but still if you are using an internal brace in this scenario, you can increase the speed of your rehab as compared to the conventional aperture fixation technique.
Sir, in this case, we took only semi-T as a graft. It is because first we did a diagnostic arthroscopy and we found it's not a complete tear. That is the reason. And what are the benefits? Because what all surgeries that I've seen, we have seen taking both the hamstring tendons rather than just one.
So it's a very, very good question. Whenever you are doing an all inside equivalent fixation, you don't need a graft length which is more than 7. Even 6 centimeters is a very good graft length if you are doing an all inside, and occasionally it is recommended that you can do it in up to a graft length of around 5.5 centimeters as well. So if you are using a single semi-T and quadrupling it, you will easily get that much of graft length. And in these scenarios, when you are doing it in an all inside equivalent ACL reconstruction, you don't need to take 2 grafts. A single semi-T will give you a very good graft length and a very good graft width as well. Like in this particular case, we were able to achieve a graft length of around 7 centimeters plus and a width of 9 millimeters. So both of them are very good as far as the graft length and graft width is concerned. So in this particular technique, the advantage is we spare the gracilis, and that will lead to a good anatomical healing in the pes area. So we don't want to do more dissection in the pes area. The post-op pain will be less and the gracilis will be functional. So ideally with this all inside equivalent, a single graft is sufficient and it does very well.
Sir, the brace that we use, in the end you said we need to tighten it we do not tighten it completely. We need to keep it bit loose.
Yes.
Compared to the graft.
Yes. So whenever you use something which is equivalent to an internal bracing, it should be fixed at a torque or at a tension which is less than that of your graft per se. So the graft should be the structure which is maximally tensioned and fixed in full tension, and you can fix it at around 20 to 30 degrees of flexion or extension. But when you are tightening the internal brace, you need to keep it little loose as compared to the native graft, and you need to tighten it in full extension. thereby preventing the over tensioning or over tightening. So we have seen some patients in which the internal brace has been over tied and the patient developed a fixed flexion deformity in the post-op period. So if you tighten it too much because it is a non-stretchable structure, then it may lead to this sort of problems.
So regarding the medial meniscus repair, like in this case, we have performed a meniscal repair. So is there any difference, like if we just left it alone, the meniscal tear?
So a very, very good question, because this was a stable pattern of tear.
Yes.
The size of the tear was also small. It was on the inferior surface. Approximately the size was around 1 to 1.5 centimeter inferior surface and almost at the meniscocapsular junction with a stable, and we are doing an ACL. So yes, it can be argued that you can just leave it and wait for it to heal. But what happens is when you start rehabilitating them, these patients may develop a fibrous sort of a union at that point. And when the patient has a re-injury in the future, there is a chance of re-injury into the meniscus. So it is better that you fix these kind of a meniscus tear with 1 or 2 stitches, that's more than enough, and to stabilize it. So that will give you a faster rehab, that is number 1, and it will reduce the chances of meniscus re-tears in future if the patient starts sporting activities again. One thing that should not be done here is a meniscectomy, because this is a very peripheral tear.
Yes,
if you try to do meniscectomy for this kind of tear, you will end up removing all of the meniscus. So meniscectomy definitely no. Leaving and hoping this meniscus to heal, yes, but with a suspicion. So it is better that we put 1 or 2 stitches and repair it so that you can stabilize it and also speed up the rehab of the patient, and you can do a better fixation so that to prevent the re-tears of the meniscus per se.
Sir, does the age of the patient also do, if the similar tear pattern is seen, we have done it in a young individual today. If you see a person with the age less more of sedentary lifestyle, working in 55 or 53 hours, so should we go with more of a repair?
Yes, yes. So nowadays age is not a bar, not a criteria for doing a meniscus repair. If your condition of knee is good, the meniscus is repairable, you need to repair the meniscus by any means. So age is not a criteria nowadays. So this type of tear at any age, I would have a personal inclination of doing a repair for sure.
Sir, regarding the cost effectiveness of this implant, usually in the government setup or in India, which is a developing country, the patients are mostly middle class or the poor. So, what are your take on this cost effectiveness of
So
this
if we talk about the meniscus repair, you must know about the types of the meniscus repair which is performed, and the cheapest of it is inside out meniscus repair. And this device, the eco stitch device that we use today, is actually a hybrid between an inside out and an all inside, in which we are using a device. So the costing of this device is between the two. The all inside repair is costly if you are using some kind of a device like a fast fix from Smith & Nephew, air from Striker, or a fiber stitch juggernaut from Biomed, fiber stitch from Arthrex. So the cost will be very high. So it may be detrimental to some of our patients who are not that affordable or who are not insured. In those patients who are very poor, I would recommend you to use an inside out technique using similar cannulas. But the downside to that is you have to open an incision, you have to put an incision on the back of the knee to do a repair, and that may cause cosmetic problems to some of the patients, and occasionally it may cause some kind of paresthesias on the back of the knee, because the cutaneous nerves and the saphenous nerve branches goes in that area. So I would personally avoid putting a posterior-medial incision because of that issue. The eco stitch device that we just demonstrated today is actually a hybrid. So it is between those two technologies, and the cost is also between those two technologies. So it is not very costly, very expensive. It is a very, very decently priced implant. It is just a little bit more costly than the inside out sutures. So still it will be usable for most of the Indian middle class patients, should not be an issue.
Sir, what should be the rehabilitation protocol for this patient?
So this patient, you can see that our ACL fixation is very good and very solid fixation that we have achieved. And luckily the meniscus was also, after the repair, it was very stable. It was a small tear and it was stable. So I will go in this particular case with a quick or a fast rehab. Normally, if I am doing a meniscus repair with an ACL, I would do with a slow rehab, weight bearing at around 3 to 4 weeks and knee bending at around a week. But in this particular patient, I have a very good fixation. So I can start the knee bending from day 1 or 2 whenever the patient is comfortable. And I would like to bear this patient to bear weight at around 2 weeks of time. So in this particular case, I would be more faster than my regular meniscus repair because it was a stable pattern tear, a single anchor, and we have just repaired the portion which was torn, the undersurface torn, we have repaired it. And the final repair is actually very good. So we can speed up the rehab of this particular patient as compared to any other meniscus repair in which there is a big tear, you have to use 3-4 anchors and things like that.
Sir, if we have a patient who is a sportsman and athlete and is by profession, is active, so will we do the same procedure that we did today for
Yes.
ACL fixation?
Yes.
And it's superior than the interference screw, that's what, or
Yes.
early
So actually, if you see the literature, still the jury is not out whether an aperture fixation is better or a suspensory fixation is better. Both of them are very good techniques, and I would say there is a slight difference and slight advantages and disadvantages of both of them. But this particular technique has an advantage of having better tensioning of the graft and avoidance of any material inside the tunnel. So these are the two advantages that place it at a relatively superior position over an aperture fixation.
Sir, what are your take on the closed chain exercises in these patients?
You can start it right away.
Okay. So is there any role of initially the closed chain exercises
Yes.
and followed by
Yes.
gradual?
So that is for all the rehab, for all the ACL rehab, we will progress in the same way.
Sir, on the middle side, that application, in the intro of the surgery that we did, is there any, you explained it very well, but how posterior we need to go and a particular side, how to check medial opening,
So most of these patients are tight on the middle side, and if you need a good space to work on, you need to do a good pike resting. So the pike resting, there are two techniques described. You can do it in an outside in fashion that we did today, or some people are doing it in the inside out with needle, but that is a bit clumsy. So I would recommend an outside in technique with a standard needle. You need to see the midline of the MCL and do it in slight posterior and slightly towards the femur. And that is basically which is called as a magic point, and you just put your needle and just put one click and you can hear a small pop like a sound. Some of the fibers of the MCL will give away, and you will have to assess and you have to grade how much opening do you want for the particular meniscus repair.
So you do this thing for all middle side repair, or
yes, if your exposure is not good, then you will not be able to do a good repair. So you need to have a good exposure. Luckily, with doing a meniscus repair after doing a meniscus pike resting, we have not seen any MCL deficiencies. So long-term results of any meniscal of MCL deficiency is not there. Usually, it will heal nicely once you immobilize these patients. So should not be a problem.
Sir, is there any role of like order of repair? Like first we should repair the meniscus and then we go for ACL or something.
So normally meniscus lesions should be repaired first, and then you do the ACL. The only catch to this scenario is that occasionally your repair may not be that strong or clumsy, and you do the ACL, you do full flexion, and you do extension, you do cycling, that may damage the repair. So occasionally some people will pass, like if they are doing an inside out repair, they will pass the sutures, do the ACL and do the knot tying in the end. So occasionally you can do it in some of the cases if you have a lot of movement or a lot of things if you want to do it at the time of the ACL. But still normally you do meniscus first and then you settle the ACL routinely. You can do it other ways also, or you can do your ACL tunnels, then you do the meniscus work and then you pass the graft. So that is also an order which some people follow. So that will not put the stress on your meniscus repair per se.
Sir, in this fixation that we didn't perform cycling.
So cycling is an integral part. So normally I recommend cycling to be done in all the cases. But here, because of the suspensory fixation, we are removing the slack anyway. Okay. So what is the purpose of cycling? Cycling is to remove the slack in the graft and to attain a maximum length of the tendon at the time of fixation. That is basically the cycling is. So here when we are doing a suspensory fixation, we are anyway doing a good cinching to do a full stretching of the graft. So it is less important in this particular technique as compared to if you are using it for an aperture fixation. Here in aperture fixation, you do a cycling and then you fix a screw. Here the tensioning itself will have an effect of elongation of the graft per se. So this is a little bit difference in both of the techniques.
Sir, in this patient, as we have preserved part of an ACL which was found, we did so the clumping now, but still we have preserved part of the ACL in this patient.
Yes.
So will that aggressive, our rehab will become more aggressive rather than if the patient with
Yes,
complete ACL
yes.
tear?
So this is what is called as a remnant preservation technique, and if you do a remnant preservation technique, you can you have a proprioception which is better, and you can increase your rehab speed as well. So definitely nowadays it is imperative that you try to preserve more and more remnants for proprioception and for a good healing as well. And if you see, we have shown in some of our surgeries that there is a very good vascularity on the ACL stump which is coming from the tibia, and that actually helps in the healing. And if you remove the stump, everything, then that vascularity is hampered. So that's why it is important. So I'll also show you that usually the healing of the graft comes from two places. You have a vascular channels which are coming from the tibia, and you have some vascular channels which are coming from the femoral insertion, and that will lead to healing. And if you preserve these kind of remnants, you will have a better healing or in the incorporation of the graft as compared to if you don't do it.
Sir, while shaving off the ACL stump, whatever there is a one lesion you are talking about, which you mentioned as cyclops. It will
Yes.
form the cyclops.
Yes.
How it is?
So normally whenever there is an ACL tear, sometimes what happens that the torn part of the ACL is flipped outside, and people will do the ACL reconstruction and just didn't see, because of the fat pad, they didn't see this fragment. So if this fragment which is flipped on the other side is ignored, then that may cause a lesion which is called as a cyclops lesion, and the cyclops lesion will cause a fixed flexion deformity. So post-op fixed flexion deformity in a case of ACL reconstruction post-op can be due to this problem. Okay, thank you. So hope you enjoyed the surgery, the live surgery and the discussion. So basically the motive of this particular live surgery was to demonstrate certain newer implants and how to do an ACL surgery with taking into consideration all the principles of the ACL surgery and the meniscus repair surgery. We would be very happy to answer any of your queries or doubts. So please feel free to contact us if you have any doubts pertaining to these techniques. Thank you.